Hello everyone. This presentation is part of the ERN educational videos entitled Challenges in Genetic Tests in Children with Inherited Cardiac Diseases. I am Anwar Baban, consultant cardiogeneticist from Bambino Jesuit Children's Hospital and Research Institute in Rome, Italy. We all know that there are different levels of biological information starting from DNA, mRNA, tRNA, proteins, ending up with cells, organs, and individuals. In this presentation, we are going to talk about DNA changes. In the last decades, we know that there is a rapid revolution and evolution of genetic testing, starting with Sanger sequencing in the late 70s, and then with Human Genome Project that was concluded in the early 2000s. Where we understood that the coding sequence represents only 2% of our genome. Furthermore, the NGS first methods started in around 2005, with first whole cancer exome sequence in 2007, and the genome landscape was clear for more than 15,000 individuals. So the more sequencing we have, the more information that we need to get for interpretation. So in other words, with Sanger sequencing, we can understand just one piece of a gene. And with NGS panel, we can understand tens to hundreds of genes. While with bigger experiments, we can understand, for example, the clinical exome, thousands, mainly disease-causing genes. And with whole exome sequencing, we can understand also coding and non-coding and delved up. So with all these experiments, we can get very interesting findings in identifying very rare conditions, or we can find more difficult data to get for interpretation. So it's really a complex path. It's never A to B, but it is rather a tortuous way. Other factors that can limit and influence genetic testing includes that phenocopies can mimic genetic disorders. For example, if we find a ventricular dysfunction, it can be caused by infection, inflammation, or metabolic conditions. Sporadic condition is very difficult to interpret. Racial disparity, since the major molecular studies are based on European background. Non-paternity. Another aspect is that we have a limited detection rate of NGS results in inherited cardiac diseases. Genetic heterogeneity is almost the rule in inherited cardiac diseases, since a single disorder can be caused by different genes, and a single gene can cause different disorders, so it's really complex. We also know that the Human Genome Project allowed us to read the letters in the Book of Life. But we do not fully understand the meaning of these words or grammar, not always. So from clinical point of view, the clinical genetics workflow starts by counseling with sampling. Prior to that, we have to get the informed consent, prescription, sequencing, alignment and variant calling, annotation, interpretation and variant classification, report, and then post-test counseling. So let's just start with an example. Our proband has long QT. The mother is phenotype positive as well. So we start with a pre-test counseling with the possibilities for the results by NGS, and we tell them that we can see a limited percentage. So the scenarios can be a negative result, normal sequencing, either because there's no genetic background, but this is less probable because this is a familial condition, or because the genetic background lies in the dark zone. The other possibility of the genetic test is that we can identify a variant, and for each variant, we need to classify it. The classification can be a benign, class 1, 2, which are usually not reported in the diagnostic results, or it can be class 4 and 5, likely pathogenic or pathogenic, and they can predispose or disease-causing. But it's very important to remember the reduced penetrance and variable expressivity. Class 3 is the genetic purgatory, or the variant of unknown significance, which does not belong to the benign and does not belong to the pathogenic zone. This classification is based on the American College of Medical Genetics classification that was started in 2015 on the basis of different parameters, different factors, which predict pathogenicity or a benign nature of the variant due to the nature of that DNA change. The frequency in the general population, is it de novo or it segregates with affected individuals? Functional studies, computational studies. So there are different factors that can influence the ACMG classification. So we have heard population databases, frequency of the variant. This depends on what we find on population, disease-specific sequence databases, but also databases for gene-specific ones. Another aspect are computational studies, which can be of help, especially in silico predictive algorithms. Functional studies are very helpful, but they are expensive, time-consuming, and difficult to retrieve for each individual that we see in diagnostic setting. So, after applying all these rules, we get the classification, and variants should be classified as uncertain significance if other criteria are unmet, or the criteria for benign and pathogenic are contradictory. Very important consideration is that the variant classification can change with time on the basis of scoring system of the ACMG criteria. So VUS can become likely benign, and a VUS, it can become likely pathogenic. Public consider genetic results deterministic rather than probabilistic. However, VUS are definitively probabilistic, and long-term follow-up and re-evaluation is to be considered for each family receiving a VUS result due to potential reclassification. So let's get back to our family. A variant was identified as SNTA1 gene, and the variant is classified as uncertain significance. So we get back to literature, and we know very well that this gene is disputed now as causative for long QT. So what we have learned, it's important to be familiar with the genes of the diseases that we look after, and very important to have constant literature revision and update. Moreover, we did the genotyping of the parents, and the mother, who is phenotype positive, resulted to be genotype negative, and the father, who is healthy, he has genotype positive. And we get this criteria. The variant goes towards the benign zone. So what we have learned is the value of family members genotyping and above all phenotyping. So let's go on with our diagnostic odyssey. And what should we do when we face negative NGS results or non-conclusive VUS? We have to go on. We do not have to stick to the non-informative results of a VUS just because it might make sense. We have sometimes to escalate to a more expensive test, for example, exome rather than panel. We have to consider, for example, copy number variation that might be missed with NGS, the importance of careful physical examination, especially for children, and to consider other conditions, for example, neuromuscular or genetic syndromes of dysmorphology, especially for childhood onset inherited cardiac diseases. Just a few words regarding the copy number variants. We all know that the genes that we have, especially the autosomal ones, we have two copies, a maternal allele and a paternal allele. And with NGS, we can see from single to several base pair DNA variants, but this method is blind for CMVs in bigger segments. For intermediate segments, for losses and gains, we can get MLPA test for certain genes, and for bigger ones, we can see it with microarray test. Another aspect are the triplet repeat expansion for specific disorders. So let's get back to our patient. NGS was not helpful, So we went on with MLPA test for arrhythmia, and it was positive for a maternally inherited heterozygous macrodeletion at exon 9 and 10 of KCNQ1. So this is a long QT type 1, and the case is resolved. Patient 2 is an example of the predictive value according to specific genetic defect. So it's a genotype, phenotype, and management correlation. We saw the patient for the first time at the age of 14 years old. He was referred from our congenital heart defects unit due to correctation of aorta, bicuspid aortic valve, some orthopedic issues. But family history was positive for dilated cardiomyopathy in the grandfather, who received also pacemaker at 50 years old, and he was heart transplanted with an intact coronary investigation. The mother of his grandfather died at the age of 40 years with sudden cardiac death, sudden death. At that time, we did not have exome possibility, so we opted for cardiomyopathy panel and it was positive for lamin A, frame shift mutation. And when we sent the mother to an adult center for cardiac investigations, she is phenotype positive and she received ICT implants. So laminopathy can exist also in children, because our patient then, he had progressive arrhythmic events from the age of 17 years old, and the age of 19, he showed both supraventricular and ventricular arrhythmias, and he received ICD. Patient 3 reached our hospital at a state of ECMO. He was 3 years old. The parents just reported mild clumsiness. However, he started walking at the right age. The speech was fine, and we saw all the videos with the parents. NGS panel was negative for pathogenic variant, and when he woke up after heart transplant, he showed dysarthria. So we did the specific test for Friedreich ataxia, and it was positive. So it's important also to remember that even in a toddler, a patient can arrive with the end-stage heart failure from Friedreich's ataxia. Patient 4, she reached our hospital at the age of 5 months old for severe dilated cardiomyopathy, non-compact left ventricle, and dysmorphic features hypotonia. We did not do NGS test, but we did microarray, and she's positive for microdeletion 1p36. We know that this zone this region harbors one of the candidate genes for non-compact left ventricle, PRDN16. So the genotype with the phenotype coincides. So this is an example of the importance of physical examination and expertise in this morphology for children. So the take-home messages: the importance of pre-test and post-test evaluation, clinical evaluation, and to be familiar with the genes of the diseases that we see daily, and always try to obtain as much as possible family studies, both for phenotyping and genotyping. Otherwise, the test can be non-conclusive. To consider other family members, phenotyping, and if applicable, genotyping. It's important to look beyond NGS when it is negative or with boost results. And we must not accept a boost just because it might make sense. And the boost classification can change with time, both towards pathogenic or less pathogenic. Always let's try to remember that the copy number variation can account for up to 5 to 10%, and that common variants and isolated populations may not be cataloged in larger databases. It's important also to remember that for autosomal recessive conditions, just to ensure that the variants are located on different alleles. So when we say a child with inherited cardiac diseases, it's very important to have a multidisciplinary management in order to get the best results. Thank you for your kind attention.